My name is Lakshi Aldredge. I'm a dermatology nurse practitioner in Portland, Oregon in the States. And I'm going to just be speaking to you about psoriasis comorbidities. And I know every one of you could probably be giving this lecture, but this is my passion. I feel like psoriasis is the modern day leprosy, and I feel like there's no other time than present where more research is being done. I do work with a lot of companies. Primarily, my role is to really promote patient advocacy of this disease state, and very specifically the role of nurses and advanced practice nurses in managing these patients, because more and more, at least in the States, and it sounds like across the world, we are the ones taking care of these patients with chronic disease, and the impact that you all have for these patients and their lives, just even with the camp, it's extraordinary how transformational we can be in impacting these people's lives. So primarily, I want to talk a little bit about quality of life. We're going to be spending some time talking about comorbidities and treatment approaches. And as any of you who have heard me speak know, I have a very difficult time speaking in a short time. Ask my family.
I'm very strict.
So I will speak very, very quickly because I wanted to include as much as possible. So this is some very, very old pictures of psoriasis. But what I wanted to point out is that it is a very common condition, unlike some of the other ones that we talked about. In the United States, about 7.5 million individuals involved with the disease. The primary ages of onset are between 20 and 30 years of age, and then 50 and 60. Now, early onset at 20 and 30 is because while you can see this in children, seems to be that after the onset of hormones in pubescence, you start to see a protective factor with the hormones helping the immune system ramp up, and then at early adulthood, you see it ramp down a little bit, and therefore it is hypothesized that that may play a role in the onset being in early adulthood. In the 50s and 60s, they hypothesized that some of the medications that we put our patients on, primarily blood pressure medicines, may contribute to that onset, as well as other things such as surgery, stress, trauma, what have you. And we all know that there is a genetic predisposition to this disease. Historically, I find this so fascinating. I love hearing about the history of diseases. Psoriasis has been around and identified in the linens of mummies' tombs. And so we know that it has been around since the beginning of time. And it was described as in the Old Testament as well. And in fact, this was the leprosy of the old day. People with psoriasis lived outside of the city wall, and they would have to ring a bell before entering the city, and people would scatter because they felt that this was a contagious disease. So again, talking about the stigma associated with this disease and the social isolation. About 40% of patients have a family member that it affects. And so I always ask my patients, who in your family also has psoriasis or psoriatic disease? That can be psoriatic arthritis, it can be Crohn's disease, and we'll be talking a little bit more about that. As I mentioned, there are numerous triggers for psoriasis, including not only the genetics, but environment. The further you get away from the equator, the higher the incidence of psoriasis. So we believe that there is some protective value of sunny equatorial weather. There's also another hypothesis that I find fascinating, and that is that the immune system of some equatorial regions, which a lot of them can be lower social class, lower poverty levels, and a higher incidence of parasitic infections, which actually ramp up the immune system, and therefore it is protective against psoriasis. So you go to the colder climates, you will see a higher incidence of psoriasis. In my clinic, where I manage very complex psoriasis patients, they often travel to the south during the winter months. In Oregon and Washington, it gets very cold and dark in the winter times, and they go to equatorial countries or to the south, and their psoriasis gets significantly better. This is also the case for patients who have rheumatologic conditions. So there is definitely something about being in colder weather that is more, there's a higher incidence of all autoimmune conditions, not only psoriasis. Now, this is really, see, I feel like angels are singing because we as dermatology nurses have come together. That's the way I'm going to think of this. Yeah. Okay, yes, sing away.
It's the lepers on the other side.
It's the lepers on the other side, right. This is incredibly important. This is why we take care of the patients as well as we do. Because as nurses, we are very concerned with the whole patient, not just the skin. So quality of life is incredibly impactful. In my group of patients, which I take care of veterans of the United States, and many of these patients have lived with psoriasis their whole life, and they will tell me, Lakshi, I don't care about my skin. I've learned to live with it. It doesn't bother me. And I tell them, but it affects your family. Every single one of the patients who have psoriasis, they are either socially isolated, they do not go to family vacations, they don't take their wives on cruises, they don't go to the father-daughter dinner dance or take their children to the pool because they don't want to embarrass their family members. This is a huge quality of life impact. And look at this, 40% have an increased risk of depression, 31% of anxiety, almost 44% of patients have contemplated suicide because of their disease. This condition has a significant impact on quality of life. Another statistic that I think is incredibly important is that a third of patients with psoriasis say that they miss 10 days of work a month because of their disease. That is a huge impact. Think about the financial impact of missing 10 days of work. These are people who lose their jobs. And in this day and age, if you lose your job, you lose your livelihood, you may lose your home. The rates of homelessness in the United States, one of the richest countries of the world, it's still staggering. And this is happening worldwide. So when people tell me psoriasis is just a skin disease, I love to show them this slide. And then I have them come see me in clinic and visit some of my patients. This is another pivotal study that was published by Dr. Armstrong and colleagues talking about the emotional and physical impact of psoriasis. And you can see over on the far side talking about self-consciousness, unsightly appearance, helplessness, and many of these patients, the average psoriasis patient in the United States sees 7 different providers before they find one that they feel is listening to them and will actually care for their disease. Some have been told that their disease is so severe they need to go see somebody else. It's too much for them to handle. That is a travesty in this day and age. And then if you look at the physical components, people underestimate how painful psoriasis is, how it impacts their sleep, and we all know if you do not get sleep, your quality of life and your ability to think and act is significantly impacted. And physical pain, the itching is unbearable. Okay, so why am I here talking with you about this? Because you all know about psoriasis. My mission with my patients now is to talk and educate them about comorbidities, because this is something that is really understood, and it's an area that is getting a lot of research. So this slide is showing you the circle, the pathogenesis, in a very simplified format. This is what I show my patients. So you have a psoriasis trigger that initiates the actual plaque. That releases cytokines and many other immune mediators that cause elevated levels of other specific cytokines and interleukins that again cause increased keratinocytes, the skin cells, as well as inflammation throughout the entire body. That causes the psoriasis plaques. The psoriasis plaques themselves release further cytokines, causing another circle of inflammation. So when patients tell me it's just a skin disease, and I've also had physicians tell me it's only a skin disease, I tell them what you are seeing on the skin is a warning of what is happening internally. Psoriasis is like a slow-burning fire. The immune system is the fire, and it's activated. And we are fortunate enough to see it on the skin because we know we can and must do something to quell that fire. Versus other autoimmune diseases such as Hashimoto's thyroiditis, diabetes, other autoimmune conditions that you cannot see, and patients may be suffering from. At least with psoriasis, the way that I look at it in a positive way is that we can see what's happening on your skin. That means that we need to act and treat it. It is now the position of the National Psoriasis Foundation's Medical Advisory Board, a beautiful publication that was done in 2016, where the target is clear or as near to clear as possible. It is no longer acceptable to live with any of the skin involved because, again, where you have skin involvement, you have that fire burning. You are not going to leave a campfire smoldering slowly. Our goal is to try and put that fire out. We are coming close to a cure. Okay, calm down, Lakshi, and move on. All right, so these are just a few of the comorbidities that we have now learned are associated specifically with psoriasis, psoriatic arthritis, coronary vascular disease, that is huge, that's heart attack, stroke, metabolic syndrome, which is a component of several different conditions, non-alcoholic fatty liver disease, chronic kidney disease, cancer, specifically lymphomas, GERD, reflux, indigestion can be associated with psoriasis, sleep apnea. Who would have ever thought that that was a comorbidity of psoriasis? Depression, anxiety, and suicidal ideation. Depression and anxiety are huge. And it's not just, and a lot of people believe this, because they're obviously wearing a very visible disease, they're stigmatized, they're ostracized, so of course you're going to be depressed and anxious. But what you actually have is inflammation of the brain, and this actually contributes to the depression and anxiety. It's a pathological phenomenon. I'll talk more about that. So screening for psoriasis comorbidities is my new mission. Every time you see a psoriasis patient or their family member, you must be asking them about other things. You need to ask about how is their heart, how is their blood pressure, how is their cholesterol, how is their mood, how is their ability to function in life. These are all incredibly important things to identify as you're thinking about some of these comorbidities. And you must start asking these questions when they're very, very young. Remember I told you that 40% of patients have a family member who has psoriasis, so there's a genetic component. So if you know that those family members have young children, you need to watch and think about those children and check their skin often. In your young patients who have psoriasis, they're young, 20, 21, you're still going to start screening for blood pressure and cholesterol much earlier because, again, they are going to be at a higher rate of developing these conditions, and so you really need to look for all of this. Very quickly, psoriatic arthritis. Unlike the skin where we can reproduce more skin cells, the arthritis, once you start having destruction in the joints, you cannot replace this. So I tell them that. If you look at your fingers, I just had a colleague I was looking at the other day. I said, what's wrong with your fingers? Oh, I've had that all my life. I said, you have joint destruction. You cannot get that back. Enthesitis is inflammation of the joints, the tendons where they attach to the joints. So it's not just the bones. Dactylitis is that classic sausage digit appearance. Nail pitting is strongly associated with the development of comorbidities. Look at these statistics. This is the one that's most critical. Their risk of dropping dead of a heart attack in their 20s and 30s is significantly higher, threefold higher than a normal individual. 78% higher risk of developing ischemic heart disease, cardiovascular disease, and peripheral vascular disease. So the take home is really to start screening very early. And again, monitor their cholesterol levels, control depression, smoking cessation, limit intake of alcohol. If they tell you they take 2 glasses of wine at night, that means they take 4. I know this because I do that when they ask me, okay? So I have very little time, but you will have access to all of these slides. I want to get to the take-home point, okay? And that is that Patients with psoriasis have to have a primary care provider. Oftentimes, the dermatology provider has to monitor these things because they don't have a primary care provider. But if you have a patient with psoriasis, especially if they have moderate to severe disease, make sure they have a primary care provider, make sure they're getting appropriate screening, and more than anything, make sure they're getting on appropriate therapy, whether that is a systemic pill or it's a biologic. In this day and age, no patient should have to suffer with psoriasis, especially if they're a young person who has their whole life left to live. And there are multiple groups, the National Psoriasis Foundation, the International Psoriasis Foundation, the Dermatology Nurses Association, British Derm Nurses, Australian Derm Nurses. Everybody has incredible resources, and it really is wonderful that we're hearing today all of the virtual resources that are available that we need to offer not only to our patients and their families, but to each other. So I want to thank you very much for your time and your patience.